flipping back to, so the slides have a little bit more information and the website has a little bit more information about the development of our ancestral land statement. Sorry, I'm just a minute. When the screen took over, I lost my notes and now I can't see the screen.
Oh, that's okay, Liz. This one is just a couple of reminders about logistics today, that we will be recording and that please keep yourself muted unless you are talking, and you can use the chat box to say any comments to get them to all of us.
Thank you.
And then on to the agenda. Can you see that one, Liz?
No, I can't.
Oh, okay. Well, this is the agenda for today.
Okay. I got it.
Okay.
Okay. So this morning we will be, our moderator will be Dr. Ed Ellinger, and he is going to introduce each of the panelists in turn, and will be moderating the Q&A. So we'll have about 30 minutes for introductions from our panelists, and then we'll have some Q&A, and then at about 8:50, we're going to move into breakout rooms with our panelists, and we'll come back. And I encourage all of you to come back, because the Q&A, the questions and answers at the end at 9 o'clock are always some of the most, it's where we really integrate all the information we've heard from across the panel. And then we'll wrap up by 9:30. And at the end, I just we'll highlight for you a few upcoming events for MPHA. And we have a lot of good stuff going on at MPHA. So I want you to know about that. We want to thank all of our friends of the forum, and they're listed here. I will share a link in the chat later that provides a link to our membership page where you can become a friend of the forum. And all of these people have made longstanding commitments to our policy forums, to see them running and so strong. And we also want to thank our organizational sponsors, Alina and Medica. We really appreciate their ongoing support. We've been working with our sponsors in different ways to create a more sustainable financial structure for MPHA. And so stay tuned for more. Today's moderator, as I said, is Ed Ellinger, and he will introduce our panelists, but we have a fantastic group. Julia Interante, Susan Mason, and Thea Bryan. So please, I'm very pleased to pass the microphone to Ed Ellinger. Thank you.
Thank you, Liz, and good morning, everyone. As we were doing the land acknowledgement, I think we should also have to acknowledge the passing of Clyde Bellecourt, who started the American Indian movement and who had a tremendous impact on health among American Indians in this country, and stimulated a lot of us to think about what's going on in the world and our role in that. So thank you for all your work, Clyde, and may you rest in peace. And it's nice to see so many folks that I haven't seen in a long time. So it's really, really nice to be here, and we've got a really good session planned for you. So let me just start by saying that I moved to Minnesota in 1980 to run the maternal and child health program at the Minneapolis Health Department. And in 1980, the infant mortality rate in Minneapolis was about 12.2. And in Minnesota, it was about between 11 and 12, but it was less than Minneapolis. But both were going in the right direction. And so actually in 1983, the Minnesota Department of Health put out a report celebrating the fact that our infant mortality was just really doing quite well. But those of us working in the city of Minneapolis knew things were not quite as well as what the state was saying. And so we put out the first disparities report in 1984 called Infant Mortality, the Problem in Minneapolis. And I have to admit that it really irritated the folks at the state health department at the time, because we were the first ones to use matched birth and death records and really scooped the state on some of the data that came out of. But the report pointed out the disparities in health outcomes in infant mortality, where the white rate was 9.2 at the time in 1980, 1981. The black rate was 20.4. And it was that report that we put out in 1984 that got me invited to present at a congressional hearing on a bill to establish the National Commission to Prevent Infant Mortality. And that committee was chaired by Senator David Durenberger and Lawton Childs from Florida. And it was held in Washington, D.C. And it was the first time I ever testified before Congress. And it was on October 31st, 1985. And after hearing a whole lot of data about infant mortality, this is what I had to say in my presentation. And I quote from the proceedings. The problem of infant mortality is not the product of geography. It is not the problem of being a heterogeneous society. It is a product of our policies. A major concern is the persistence of social and racial disparity. The technological capacity of modern medicine cannot erase the legacy of larger social inequities. Equity in infant outcomes can only be achieved when inequity in infant outcomes is addressed and addressed directly. And the direct reduction in Black infant mortality must be directly related
Hello, along. This is
to a
Paula.
more fundamental commitment to a more responsible and just society. Those were the words I said.
Okay, let me hang on just a second.
All right. Senator, I remember particularly Senator Durenberger's response. He said a quote that I remember very vividly. He said, "Statistics are a lot like a fig leaf. What they reveal is suggestive, but what they conceal is vital." And he was identifying the fact that the data were there, but what the presenters were identifying in terms of the impact really revealed the data were concealing a lot of what the trauma was happening in communities. And sadly, what I said back in 1985 is still relevant today. In fact, it's even more accurate. In 1981, the Minneapolis infant mortality rate, as I said, for whites was 9.2 and the Black rate was 20.4. In 2017, the white rate in Minneapolis was less than 3 and the Black rate was 9.4. So the ratio is worse today than it was in 1981. And the Black infant mortality rate in Minneapolis in 2017 still didn't reach the white infant mortality rate in 1980. In 36 years, we had not closed the gap. I mean, to me, that's unacceptable. And yet we accept it as just sort of the way it is. So that's why I was pleased to see that this year's theme for the MPHA forums is local and global, what we can learn from each other, and particularly what this forum about challenges in maternal and child health, how we can explore the local and global challenges and what we can learn from each other in addressing the issues facing moms and babies. And it's particularly good because we really need to learn from other places. Because since I've been in maternal and child health, the United States infant mortality rate compared to other high-income countries has been deteriorating. Back in 1960, the US was 12th. In 2020, it was 51st. And our maternal mortality rate, we're 55th in the world, and the only high-income country where the rate is increasing. So we have lots of challenges that are facing moms and babies. And so we have 3 presenters today who are going to help frame some of the challenges that we have. And then we're going to be opening it up to some questions for the people in the audience, and we'll have a nice discussion. And so I'm going to introduce each one of these at a time, one at a time, and then they'll do their presentation, and then we'll get into a discussion. So the first presenter is Thea Bryan. She's a community health and well-being and partnership manager at Health Partners. All of the more information about her is in the link that you have in the chat, but she focuses on designing, managing, and promoting individual and community well-being solutions and partnerships with a special interest in perinatal and early childhood disparities and outcomes within communities of color. And I was interested in the fact that she leads a statewide partnership focused on brain development within the first 3 years of life called the Little Moments Count Initiative. So Thea, you're on, take it away.
Wow, thank you, Ed. That really, I think, was an amazing kickoff. And really, probably for most of us here that have been working on these topics for a long time, really pulling us back to where we've been and how we got here. I think I just always like to open and say, my perspective. I'm so excited to be partnered with our policy experts today and the other great folks that are calling in as participants. I've seen, some of my colleagues on this call. And so I'm excited to have them here too. And of course, to chime in through the chat if I miss anything. This has been a really unprecedented time in history that we find ourselves here in January of 2021, right? And my comments today, I'm going to just take a little bit of time to do an intro and really, I think, focus on some of the positive things that I've seen over the last couple of years. And promising things. And I think as I was thinking about what do I want to talk to this really amazing, engaged public health alliance about? And I thought, I want to talk to them about partnership. And I think the power of partnership and really, we can accomplish a lot separately, but really together is where the magic happens. And I think, through some of the ways that we're partnering in the community with public health and other private entities. It's been really interesting to see. And I think a couple of things that have happened in the last couple of years, COVID, of course, but also, really the racial justice emergency visibility that the murder of George Floyd created has been a really, I think, transformational factor as well for all of us. Both in public health as well as for those doing public health in private organizations as well, and a factor that I think has helped maybe get some of the disparities pieces a little bit more front and center, and to get a stronger audience on those topics as well. And so, my comments, of course, are also coming from the perspective that I get to parent 3 kiddos, right? So I'm past that 0 to 3 age now. I have an 8-year-old, I have a 13-year-old and a 14-year-old. But it's really been interesting, not just being in the community and public health space and the work that we're doing in this time, but also just seeing, the adaptations of the different systems and then the direct impacts on, my kids, their peers, families, et cetera. In relation to the work that we're trying to do through the statewide Little Moments Count work, that really what we're trying to do there is to bring all sorts of different partners together and use our best ideas and pool our resources in order to create change. And so we have been able to I think have some interesting conversations through that work in pulling cross org healthcare partners, which in Minnesota, I know many people probably have experienced and sensed there's quite a lot of competitiveness typically in healthcare spaces. And there are even rules when you get into the health plan level about different things that plans, disclose to one another and things like that, those are all set up for good reasons. But I think it does create a little bit of defensiveness partner to partner typically. So, the having to come together and solve some of these really large issues, racism, talking about those issues and how we help to break through COVID and racism together, how helping our schools adapt, helping our public health and healthcare systems survive during this time. It's really, I think, been an interesting time to be in this work. And, we see really positive things. We see both positive and negative things happening. And I wanted to share, one of the initiatives that we have within Little Moments Count is, of course, we have a strong background founding, and then monitoring with goal setting and related to evaluation. And we have some great partners at the Health Partners Research Institute, as well as the University of Minnesota, Bethel, and other institutions that have participated in helping to form these plans, as well as just really amazing participation from cultural organizations like NAS in helping to kind of vet that, are we asking the right questions to actually get the information that we need? So I wanted to give folks, this is not, we're not ready with a formal report at this point, but we did have a chance, because we had already planned and we're able to field what we call our Learn survey. And this year we were doing cultural community and Medicaid oversamples in 5 cultural communities, and of course Medicaid insured Minnesotans, parents and caregivers with kiddos 0 to 3. And so, some of the interesting things that we learned was that, we had a lot of people that we were really surprised that they said, I actually felt that this was, the last couple of years with COVID, it's been neutral for my family. I feel like we haven't really noticed huge differences. Maybe they were, at-home families before. So, this just maybe created wrinkles for them, but they really overall had either positive or neutral things to say. Not surprisingly as well, we also saw the other side of the coin, which is what we see in the public health data, I think, right? And in systems data around, a 400% increase in childhood mental health diagnoses actually needing support without a system to be able to support that. So trying to create some, innovations in those ways to support families. So, although they didn't say that, we can see some of those things come through in the data. I'm just kind of voicing, I think, what all of us are experiencing. And it's also given us a chance with the Little Moments Count work to pull, just as I said, reduce competitiveness across healthcare systems. And we have about 9 healthcare systems at the table working together, sharing best practices to actually be able to get as effective as we can at helping to educate and support parents. And I think that's really helpful, especially because, of course, where we see, just like many public health metrics, where do we see the greatest gaps? We see the greatest gaps in non-white Minnesotans. So by focusing and really engaging community and empowering community to help create solutions, right? Because the best solutions don't always come from us public health folks, but really parents. And so, I mentioned the Learn survey. We also have done some dedicated focus group work, working directly with our community partners and getting parent voice represented, even on things like, what do you see? What are your wants for your children? And what do you see as success? And it's really interesting to see community, how that does differ, and what a really important piece that is in crafting our messages and really working together to be as effective and helpful as we can. I don't know how I'm doing on time here, but one other piece that I wanted to mention that I feel really passionately about, you'll see in my bio, I am a internationally board certified lactation consultant as well, and really got into that work I'm not a nurse, I'm not a doctor, but got into that work because of seeing gaps that existed. And now work on this system-wide, about 25% of my job, and outside of that, we include it in Little Moments Count, but there's also great parts that, of course, we work with public health in many different ways, especially WIC here in Minnesota. We have an amazing breastfeeding supported WIC group here in Minnesota. We're very lucky. And so one policy related thing that I did want to call attention to in case people haven't seen it is this, the enhancements in policy, both at the national and at the Minnesota level, around laws protecting a parent's right to take time and be guaranteed a safe place to express their milk during the workday. They've reduced the number from 50 employees per site to actually 21 to 15 or more employees in total, which is a huge change. And because, there are many very small companies that kind of would fall under the radar that many people would work for that just wouldn't always be in the headspace to be able to understand how important it was to support their employee. So having these policy safeties in place to use when we need to are very important. There's also some additional pregnancy, needs during pregnancy pieces that are also nice adds. And the Department of Health has created some great materials to educate and to help with implementation on these things with employers. So I have lots of different links that I would love to provide and share with the group after as well. But I honestly don't want to take too much time because I'm so excited for Susan and Julia to be able to speak too.
Thank you, Thea. Interesting information. And you bring up some important issues and some that are contradictory, like partnerships and competition, which are both important, but sometimes get in the way of each other. So we love to get back to some of that conversation when we have our Q&A. So let's now move to Julia Interante. She's an advanced doctoral student in the Division of Health Policy and Management at the University of Minnesota School of Public Health. And her focus is maternal health, particularly racial and geographic disparities in maternal health outcomes, and particularly access to obstetric care or lack of access in rural communities, and the structure and financing of postpartum care. So Julia, take it away.
Thank you so much for that introduction, and thank you for having me. I'm very excited to talk about this really important issue. And as Ed mentioned, my focus really is in maternal health. And he already mentioned in his intro about rising rates of maternal mortality in the US. And we really see huge disparities in that when it comes to race. So Black and Indigenous moms die at a rate 2 to 3 times higher than white moms. And that's actually worse in Minnesota. We actually see Indigenous moms dying at a rate 8 times higher than white moms here. There's also geographic disparities in these rates. So rural residents have maternal mortality and severe morbidity rates that are 9% higher than urban residents. And we see income disparities too. So patients on Medicaid have a 30% higher rate of severe maternal morbidity and mortality than those on private insurance. And the risk of this is really compounding at the intersection of these identities, which is often not looked at. Usually researchers look at one area of this, and it's really the intersection of all these is a really important cut of the data to look at that not a lot of people are doing. And when we think about what makes a healthy pregnancy and a healthy mom, people often just think about what's happening prenatally and during childbirth, but it really starts before that and goes well beyond that. So thinking about access to preconception care and what's happening before pregnancy. So say a person has uncontrolled diabetes before they get pregnant and don't have regular access to care, then the risks are going to be just complicated during pregnancy, and it's harder to manage at that point also. And then again, there's been a lot of focus and interventions on what's happening prenatally in childbirth that are really important, and there have been some good changes there, but we've kind of left it at that and forgot about what happens postpartum, where a lot of the focus really does end up being on what's happening with the newborn, and the moms really often get left out here, which is not okay. And so we really need to focus on what's happening postpartum, and half of all maternal deaths actually happen after childbirth, so that time period is really important. And then again, also thinking about what happens beyond that. So this is thinking about continuity of care, transitions to well women care, and having access to insurance that goes beyond the traditional 60 days is what Medicaid currently has. Thinking about all this stuff around access, there's been huge losses of access to not just rural hospitals, but obstetric care within those rural hospitals that we've seen happening for decades now. And this is really detrimental because already in rural communities, we see patients are sicker leading into pregnancy. They're often lower income, have less access to resources, have more barriers just from distance and transportation. And currently only 40% of rural counties have access to any obstetric care, any hospital-based obstetric care. And again, the losses that we've seen in access to obstetric care has really been focused in the most remote rural counties. So it's not like people are losing access and can just go over to the next county, urban county that has obstetric care. Some places it's really like hours patients are driving now. So for example, in Grand Marais, when they lost access to obstetric care quite a few years back, now those patients have to drive all the way to Duluth to give birth. It's an extremely long drive when you are pregnant and not knowing what's going to happen. And again, this just expands disparity. So patients who can afford to drive down to Duluth, rent a hotel, stay there until their pregnancy comes, have those resources, which is already challenging enough. But if you don't have that, then you kind of are out of luck there, which is not okay also. And again, when we look at this nationally, these losses in rural areas are really concentrated in the South, in areas that have not expanded Medicaid and where the majority of rural residents are Black. And so part of this low access and forced structure of how we do maternity care now is really due to, part of it is due to how we pay for care. So as a society, right, we show what we value and how we finance things, and we don't put a lot of money into maternal care. So for example, Medicaid pays for half of all births nationwide, yet it pays almost half as much for obstetric services as private insurance does. And again, this disproportionately impacts non-white patients who are overrepresented among Medicaid recipients, and rural residents who are also more often on Medicaid than urban residents. And again, so a lot of times how we pay for postpartum care is using what is known as the global obstetric fee. So all of prenatal, childbirth, and postpartum care is paid as a single fee at the time of childbirth. So there are less incentives to ensure that patients return for postpartum visits. And also the structure, the amount we pay really only covers a single visit, which is not adequate. So there have been recommendations that have come out. American College of Obstetrics and Gynecology updated their recommendations back in 2018, suggesting that instead of the standard that we have right now, which is a single visit at 6 weeks, which is based off tradition and not on science, and it's too late for prevention for a lot of factors and not long enough to see the continuity of care that goes on beyond 6 weeks. So the ACOG recommendations now say initial visit within 3 weeks, initial contact with a provider within 3 weeks, follow-up as needed, a comprehensive visit within 4 to 12 weeks, covering more than what we currently cover, and then transitioning into well-woman care. And again, we have not updated the payment policies to support this type of care, which is what we really need. So again, I've already talked a little bit about postpartum care, and it's the US healthcare system is uniquely fragmented, especially around maternal care compared to what we see in other countries, and it makes it really difficult to make some of these changes. And we actually do a really poor job of collecting data on what's happening postpartum, which makes it really hard to do research and provide evidence and support to make these policy changes that are really important. And so I do want to just finish quickly on a few current policies that are important, that have been some positive things that are going on. There's been a rise in maternal morbidity and mortality review committees at the state level, which have done really important work. There's also been, with very recently, extension of postpartum Medicaid that has been allowed at the state level that a lot of states have started adopting. Again, the new recommendations on changing the structure of postpartum care. There have been some specific examples of changing reimbursement policies to provide patient and provider incentives around specific aspects of postpartum care. There's also the Rural Maternity and Obstetrics Management Strategies, or RMOMS, that has come out that's really focused on collecting data on rural hospital obstetric services and building rural obstetric networks to help support what's happening in rural communities. There have been talks about Medicaid adjustments for low volume hospitals and training for emergency obstetrics and care bundles to address racial disparities in maternal health. But again, a lot of these are smaller pilot programs that have not been implemented on a larger national scale. So hopefully this is the direction that we are heading more. So I will end there, but I could talk about this stuff forever. Thank you very much.
Julia, thank you. Covered a lot in that 7 minutes that you were allotted, and it's a huge topic and one that we could have, you know, a whole day seminar on. So thank you. And I'm particularly struck by the fact, as you're talking, and as Thea also mentioned, in terms of the racial disparities, that some of our policies, they're structurally racist. Medicaid payment system is structurally racist. And so we need to address that. So thank you for your words. And our third presenter, Susan Mason, Dr. Susan Mason, Associate Professor in the Division of Epidemiology and Community Health at the University of Minnesota. She's a social epidemiologist whose research focuses on population health impacts of adverse and traumatic experiences. I think that's ACEs, including childhood abuse and neglect, sexual violence, racial segregation, and other forms of violence and social marginalization. Susan, you're on.
Thank you. This is really fun to be here. I am a maternal and child health. I have a master's in maternal and child health. So my heart kind of lives in maternal and child health and my head lives in epidemiology, and it's a good partnership. And I just wanted to say that before I discovered public health, this is a very common story, I thought I wanted to be a midwife. And in college, I actually spent a couple weeks actually in the Netherlands shadowing a midwife and living with a family friend who is a family physician. And it was amazing. It was really eye-opening to see the process. As many of you know, probably the Netherlands, about 40% of births occur in the home with midwifery care. And the process there is that the midwives would actually be in touch with the family physicians when that baby was born. And so I went with this family friend as a family physician on day 3 to the home with a newborn. And the difference that makes, that A, there's so much integration, and B, that they're meeting these families where they are. They're not asking a new family to schlep a newborn, hours or whatever. It really was, it just gives you a sense of how different things could be and really how inadequate our system is. So anyway, little background information. So I just wanted to talk today. I want to zoom out a little bit. And I want to talk about what I see as a pretty big advancement in maternal and child health conceptually, which is this really, I think, a deeper understanding of life course, the life course roots of health. And so, there really has been a lot of recognition over the past few decades that health is developed over the entire life course, and that certain critical periods are so important. This is something we've known for a while, but it's really entered the mainstream, I think, in a different way over the past maybe 30 years. There's been a lot of greater understanding of the developmental origins of health and disease. And some of that is emphasizing what happens in utero, and even going back generations, the health of mom. But also we understand increasingly how critical childhood is as a foundation for a lifelong health. So we really understand today a lot more about the extent to which the health of a person in adulthood is really inseparable from their experiences as a child, and the extent to which the health of children is really inseparable from the health of their parents and well-being of their parents and caregivers. And this is a concept that's always been at the core of maternal and child health. But again, I think it's increasingly entering the mainstream and something that we talk about across different disciplines. So part of the overall advancement in this work has been around this concept of adverse childhood experiences, or ACEs, and that's where I've done a lot of my more recent work. So ACEs are things like, I mean, there's a lot of discussion about what should be considered an ACE and what shouldn't, and I'm not going to get into that. But generally speaking, these are psychosocial stressors, things like a childhood abuse, neglect, and household dysfunction, such as parents being significantly mentally ill or dependent on substances of some kind, that occur in childhood. And I would basically describe these as kind of developmentally disruptive psychosocial stressors that occur in childhood. And we increasingly have evidence that these have lifelong consequences for mental and physical health. The other thing that we know is that ACEs are quite common, much more than I think people long realized. I mean, we thought these were sort of like rare events, childhood abuse and neglect. And in fact, we now know that that's really not true. Over half of adults report at least one ACE. When asked retrospectively, but our prospective data actually shows also a very high prevalence. There's been some really interesting work with like life table methods looking at child protection data. And what they find is that 1 in 3 children will be involved in a child protection investigation for abuse or neglect by the time they turn 18. And this number rises to 1 in 2 for Black children. So you can see the extent to which families are interfacing with our child protection system. And I have a whole thing about whether that actually says anything about whether there's actually abuse and neglect happening and what that says about the system, but I'll save that for Q&A if people are interested. That said, I do think ACEs are a health equity issue. Marginalized families face significant stressors that make parenting challenging. Any of you who are parents know that it's much harder to be a good parent when you're stressed out, when you don't have resources, when you don't have support. And I just want to emphasize that this is not about individuals from marginalized groups being bad parents, but about the conditions of marginalization making it difficult to parent, that it is these conditions. And we don't think about that nearly enough, I think, in our society. COVID-19 has definitely placed additional stressors on families, while at the same time reducing our capacity to monitor things like abuse and neglect, which we traditionally track through child protection, which we get reports from places like schools and healthcare providers. You know, it's been very difficult to track this because our traditional surveillance systems have broken down. Colleagues and I did do kind of fun is the wrong word because of the topic, but it was an interesting study looking at Google searches for terms related to abuse and neglect victimization. And what we found was a notable increase in searches related to child abuse and neglect after, not immediately after the pandemic, but after the pandemic unemployment compensation program ended. So it was exploratory. It can't attribute causation, but it does certainly provide some evidence that financial supports may have a protective impact for child abuse and neglect, even in times of major disruption, such as the pandemic. So at this point, we've had decades of research on ACEs in health. We know how common they are. We know that they at least are very strongly associated with later health. They are a major public health issue. And yet advancements in terms of addressing ACEs, I think, has really been very disappointing. I would argue, I did a scoping review of literature on ACEs with colleagues, and you know, what we found is that although ACEs were initially studied as a determinant of public or population health, they increasingly are framed as a clinical phenomenon. And the implications have increasingly become clinical in terms of their utility as sort of like a screening tool. And I actually would argue they have very dubious utility in a clinical context. And very little published work has investigated what policies and interventions could be used at scale to prevent ACEs. Some of the work with parents is certainly trying to make a difference there, but really not nearly enough emphasis is on that. This limited attention to primary and primordial prevention of ACEs is really paralleled by our disproportionate funding and policy priorities. So one estimate suggests that we spend 9 times as much intervening in the aftermath of abuse and neglect as on trying to prevent it. There's just so little investment in upstream solutions. I'm talking to a public health audience, so I'm hoping you all feel as dismayed by this as I do. So anyway, to just conclude, I just want to say, I think that, from my perspective in this world of life course health and early adversity, I think in order to really advance maternal and child health and public health, we need to resist this urge to move toward the clinical and the tertiary and the downstream, and keep our sights focused on prevention, even when it feels really, really hard. I think we need to move away from a punitive mindset when it comes to ACEs, and instead think of how we can change the social determinants that shape individual parents' behaviors and choices. Let's stop blaming parents and start thinking about what we actually offer parents that supports what they do and the important job that they do. And then finally, I think we need to sort of return to a recognition of interrelatedness. We have such an individualistic culture. And really, we cannot separate children's well-being from the well-being of their families. And we cannot separate family well-being from the community and broader social supports. We want to sort of atomize all this and put it in buckets. And it doesn't work that way. So anyway, so that is my plea to public health, but maybe I'm probably preaching to the audience, the choir here, but that is sort of my hope, is that we really think about the family and how our society and our policies can be better supporting families as kind of the cradle of lifelong health. So I'll stop there.
Thank you, Susan. And you brought up one of my pet peeves. We talk a lot about trauma-informed care, which I mean is appropriate, but how do you prevent the trauma in the first place? How do you prevent the trauma in the first place? We need adverse societal conditions lead to adverse childhood experiences, and so we need to really focus on those. And I do think the way you started out your presentation, Susan, is really what this forum is about. It's called Local and Global, what we can learn from each other. And so I'm curious, particularly with Thea and Susan, because you focus on early childhood, how do ACEs play out in European countries? Do they have the same kind of impact that they have here, or do they address them a little bit differently?
That is a great question. I mean, I think one of the real frustrations of doing work in ACEs and early childhood adversity is our data are really insufficient. It's really, so I mean, retrospectively, you can ask people what they experienced in childhood, and I think that's okay in many instances. But I think when you're talking cross-culturally, it becomes really difficult because a lot of it is filtered through perceptions of norms, and so I don't know how to compare data on that across cultures. And then if you're trying to talk about something perspective, our child protection systems are very, very different. So how do you actually get a handle on even the prevalence of these things across cultures? In terms of impact, I don't know. I mean, there's definitely been work in the UK on ACEs, and they certainly see similar impacts on later life health. One might think that some of the protective safety nets that are in place in some of the European countries may be preventive, but I just don't know the answer to that question. Thea, do you have thoughts on that?
What's your take on that?
Well, I wish I had data. To Susan's point, I have not seen much on that, except exactly what Susan stated, which was really about that similar. And I think it probably depends upon the country, and it also depends upon the supports in place. I think, in the community setting, I've heard, on the other side of ACEs, some really awesome discussion. 0 to 3 had some wonderful presenters on the BESA's work, kind of on the other side of ACEs, the benevolent early childhood experiences. And I know I think in Kansas City, they actually have a community-wide initiative. I'm going to get the name wrong, but something like HOPE, which is really set up to try to work together kind of across boundaries to do exactly what we're talking about, get better at support families. I'm not aware that it extends back to the other comments more about broad economic support in the way that would be probably needed. I know that there are some different pilots that I've heard about in different parts of the country. I think we have a subset here in Minnesota of income supplementation as well for families. So I know that there's just such great work happening, and I love forums like this so that we can all come together and say, you know, what do you know? What have you read? And what do we think, back to this partnership concept, we could work together on to really help to solve this issue?
Well, you're getting at what I was hoping we'd get at, is some of the paid child leave, you know, maternity care leave, paid family leave, paid sick leave, minimum wage, home visits, you know, education that's available much more broadly than it is here. That's what I think are some of the policy issues that we have to get at.
Yeah, can I just chime in and say that this isn't cross-cultural, but there has been, I would say in the past 5 years or so, several studies that are actually finally looking at this with regard to abuse and neglect. So taking advantage of sort of policy change as a natural experiment. And there is evidence of protective effects of increases in the earned income tax credit, increases in the minimum wage, paid family leave, and Medicaid expansion for child abuse and neglect. Now, it's not a huge literature yet. So, you know, it's always easy. There could be some publication bias. There may be some null results floating around out there that aren't being published. But it is very encouraging. I mean, not that those are easy solutions to implement, but it is encouraging to think about, you know, these kind of big scalable things where you're not having to ask individual families to do yet more, jump through more hoops in order to get supports. So anyway, so I am encouraged by some of that new work that's being done.
Right. And Julie, I want to get to you with some of the issues that you raised, and particularly, you know, we are so hospital, you know, and you talked about hospitals, and we're so hospital focused and so physician focused. What do you think about expanding our role of birth provider, the role of doulas, the nurse and midwife, the role of community health workers, and freestanding birth centers, home births, some of those things that in other countries they do a whole lot more and have better outcomes than we. How are we dealing with that here?
And like, for example, in Europe, right, like 80% of births are attended by a midwife. In the US, it's 20%. And that's only been recently increasing. And I think the history here is really important and very telling for where we are now. So midwifery used to be common in the US, and it was largely like women of color who were midwives, right? And we put into place policies that were racist, that took those women out of providing childbirth care, right? And so it's only been slowly coming back in the US, and it's mostly in urban areas, largely serving white, middle and upper class populations. And I think there's been some work in Minnesota. There's some midwifery practices starting that are focused on Black midwives and Black patients. There's some work in New Mexico, where I'm originally from, on indigenous midwifery practices and bringing those back, that I think are really encouraging. So I do think that is really, really important. And I think when we think about what's happening to access to care in rural communities, we really need to look at a holistic approach here. So yes, we do need hospitals for those cases when you do need an emergency, a necessary emergency C-section. Like we have to have those backstops, and we need to have, even if it's not that hospital right there, but at least transportation and communication between hospitals and networks set up. And there is some work happening around this, but being able to support those communities by increasing access to doula services and midwives and freestanding birth centers, I think is really important, because most childbirth is uncomplicated. And so having that as a basis, and then again, building up the support systems, having access to obstetricians and hospital-based childbirth services. I think you really need that holistic approach there. But I think building up that workforce in a way that includes representation of the different communities who are birthing people is also really important there.
Yeah, there's increasing data about the race concordant care, and one of the ways to get race concordant care is through doulas and community health workers, and more community-based providers, so this and gender-based gender concordant care. Also, just recent article about that. All right, well, we've talked a long time here, so I know the audience wants to have some interaction. So I'll turn it over to Lindsay to break us into breakout rooms and have the conversation go on in smaller units.
Great. Thank you so much, Ed. Thank you to our three panelists. Yes, we want to hear about what you all have been thinking about as you've been hearing from our panelists this morning. So we will be asking you to go into a breakout room and create some questions for our panelists. And you'll have about 10 minutes in those spaces. And then please join us all back here. We will close the breakout rooms and continue on with Q&A questions that have come directly from you all. So Mary, the Executive Director of MPHA, will be now putting you into breakout rooms. So please accept that request, and we'll see you back in about 10 minutes, and you can route the questions to me when you get back. All right. Thank you, Mary, for your help. We'll see you back here in a little bit.
Great job, team.
Recording. There it goes. The recording in progress. Okay, hope you had wonderful conversations in your breakout rooms. My name is Lindsay Fabian. Please direct questions to me in the chat, and I will route them to our moderator. So while everyone is preparing the questions to me, Ed, I'll turn it back over to you to kick it off with a few more of your questions, and then I'll start feeding you questions from the audience. So please, everyone, feel free to send questions to me in the chat. Again, Lindsay Fabian. All right, back to you, Ed.
All right, thanks, Lindsay. We had some, for the audience, we had some conversation while you guys were in small groups. We had our own little small group, and it really struck me from our previous conversation and in our side conversations that we have, Minnesota has, according to the Commonwealth Fund, the best medical care system in the country. And, from my work at the Minneapolis Health Department and my work at Minnesota Department of Health, I think we have one of the best public health systems in the country. We heard about some of the innovations that are going on here, yet we're not making any progress. I mean, as I mentioned in my introduction, African-American infant mortality is even worse now compared to whites in 2020 than it was in 1980. Why aren't we making progress? Despite all of this good stuff that we've got, why are we stuck? I see smiles, but I don't see.
Is that a question for us? Well, I would say sort of, well, first as an epidemiologist, I think in some ways it's important actually to define progress. So, from a ratio perspective, it's true that the gap has increased. And yet I also think it's important to acknowledge the deaths that happen when you go from a rate of 20 to a rate of 9 or whatever it is in infant mortality. I do think we need to acknowledge that is life saved. So I'm not, that's just maybe a little bit rose-colored glasses, but I also think, we need to think about difference measures as well as ratio measures in terms of disparities.
Yes, well, we also look at, an average, we're getting better, but the disparities are there. That's an equity issue. And
absolutely.
Other countries are getting better much quicker than we are.
Yes.
So what are we not doing?
Well, I don't think we're addressing the social determinants that you talked about right at the beginning, right? I mean, with the level of inequality that we have accepted and we've seen widen over the past few decades is pretty astonishing. It creates just enormous, to me, infant mortality, if you see infant mortality, what that tells you is that you have these, it's not a question anymore. It's that is the marker of this kind of social inequality. And unless we take that seriously and actually do something about it, I don't know how we're going to address it. I mean, we can try to sort of band-aid it up with some medical care, but that's tough if people don't have access to it.
Yeah. And Thea, you talked about partnerships and competition. I mean, is our economic system, which is based on competition and capitalism, does that contribute to our unhealthy outcomes? You know, which is not based on partnership, but it's about, I'm going to do better than you. I'm going to use the capital of both human and financial capital to make profit. Does that get in the way?
Well, I'm not sure, Ed. I'm entirely the best person to answer that. Not an economist, and I don't know how to break all of those pieces down. What I can tell you, working for Health Partners, is that I do see, our leaders and other care systems and plan leaders really trying to think differently and work directly with these amazing community-based organizations that we have here in Minnesota. And I think the rate pieces, for those of us that work in public health, we know that stuff takes a long time. And we're hoping, I believe, for those of us that are involved in these spaces, that a lot of the wonderful innovation, and I think in particular, not just innovation in the listening to cultural communities and actually, being respectful and integrating those practitioners alongside traditional medical care, but also helping to empower and build capacity in communities for communities to actually lead on this issue is where we will, I think, start to really see changes in the rates. I know I see Antonia. Thank you, Antonia. I was talking about iChirp while we were on break. So, in Minnesota here, we have the iChirp, the Integrated Care for High Risk Pregnancy program, with led by some really amazing individuals at the African American Babies Coalition and the Cultural Wellness Center with Wilder's support. We've got, in Ramsey County, a group that I participate on that's just doing really wonderful work on the, really working together, led by the community, to look at not just the the data, but the other pieces that are really important to the community, celebrating birth, working on trying to optimize that culturally grounded and appropriate care, training practitioners of color to also be there alongside families, because the more we see new studies come out every week, right? Just about we need to do all we can. The outcomes are there when a family gets to have a provider of their choosing that understands their culture. And so it's just going to take a while, I think, for all of these pieces to come together. But I'm excited about the fact that we're all here today talking about this, and we can work together on solutions to hopefully see those rate changes over time.
Yeah, and Julie, we had chatted about the fact that some of these prevention, and everybody had talked about prevention actually saves money, and Thea mentioned competition, but are they competing? Are people competing over health outcomes, or are they competing over market share? Or are they competing over generations, particularly in, like freestanding birthing centers and using doulas and midwives? It may not maximize profits, but it may improve health outcomes. Are we competing about the right things?
Yeah, so I also am not a health economist, but I have worked with many. But I agree, it's so hard to make some of these changes when our competition is about profits, right? And our whole healthcare system is set up to be a for-profit system, and it makes it really challenging. I think there is some work on, again, like community and collaboration across providers, across networks, that is encouraging and could be replicated. And I think that's important. Yeah, it's difficult.
So what are you learning about our healthcare system, about our public health system, and about all the other systems that impact health, the education system, economic system, with COVID? What are, from your perspectives, what are you learning? What's, we need to learn from this pandemic. What are we taking away from this? Susan, what are you learning from this?
I mean, one thing that has been on my mind is the extent to which we have formal public health infrastructure. And I define that very broadly, that to include both sort of people who call themselves public health, and our healthcare providers, but also schools and, these formal systems. But there's sort of an invisible public health infrastructure that we haven't really appreciated or valued. And that tends to be what happens in homes. So parents who can stay home with their kids when they're sick, getting people to appointments. There's the people who are case managers for individual families. And so, and this obviously, I think that the nature of that and the extent of that really depends. That's kind of different across different subpopulations in terms of the need to rely on these more informal systems versus the formal systems. And so for me, one thing that's been on my mind is like, how do we actually make that visible so that we can start to value it and invest in that? Because that's been kind of the final safety net that we've, basically all the other things kind of crumbled and we sort of landed on this sort of informal structure, largely of women's labor, that was not just childcare, but a whole bunch of other stuff. And so can we think about that as sort of part of our community health work that's already happening, but figure out how to support it better? Or if it's not appropriate for people within homes to be doing that in an unpaid sense, do we need more community health workers who can help with case management and things like that? So anyway, that's very big picture and maybe abstract, but that's kind of been on my mind, that we really need to value this other stuff that's happening in the background that has been, I think, largely ignored.
Right. Thea, what are you learning from the COVID pandemic and its impact on all of the systems?
That's a big question. Let's see. So, I think, we knew it before and we've mentioned it already, but just how do we get better at supporting families? And, with our lens of healthcare, we've just talked a lot about, I think, building in, and this is kind of back to that little moments count work, talking cross partners. We have a total of 57 partners and about 9 healthcare systems at the table, and really sharing how each system is supporting families and learning from one another. I always going back to partnership. And that's really been magical. It's been interesting. We've taken time with pediatric care leaders and CEOs there to actually say, like, what do you see? How do we get vaccines deployed? How do we do testing? Were you able to, Hennepin Health was able to get, and a couple of other care systems, vans deployed out into community to keep up with child vaccination schedules during COVID-19. And so I think there are things like that that we'll take away from all of this that are really transformational in how we think about not just how we think about problems and solving them, but solving them together, even if it's learning from one another, even if we're kind of doing it on our own. But I do see more partnership and more willingness to actually get together and talk about those topics. Through the CHIP work in Hennepin County, we have spent quite a few meetings actually doing that as well. And that for me has been really interesting to learn from other organizations. What's working? What are you feeling and experiencing? How are you supporting your people? I think that piece of all of this for all of the first responders and parents and families, and really all of us at this point, everybody's feeling so fried. And so those ways that we can learn from one another about how do we support one another and deal with that, and then how do we support families that are really struggling? What capacity is there across systems to ensure that that those that need it the most can actually get the support they need. And there have been some really groundbreaking conversations cross systems on those types of topics, back to that individual family level too.
Julia, what's your takeaway?
Maternity care space, what's happened with COVID has been interesting and challenging at the same time. So I definitely worry about the rural healthcare workforce and what that means for keeping obstetric services in rural hospitals. I mean, we know that COVID has put a huge strain on healthcare workers and financial strains on rural hospitals. And often, unfortunately, one of the first services lines that we see go in rural hospitals is obstetric care. So I think that's a challenge. I think some of the innovation around telehealth is really important. I don't think it's a cure-all, but I do think that in thinking about access to prenatal and postpartum care, that doesn't always necessarily need to be in person, just a touch point with patients that can really increase some access, but also being aware that we really need to think about equity when it comes to telehealth. So thinking about rural areas where everyone may not have adequate internet, and thinking about, again, like patients who may not have a safe, quiet place in their home to be able to do a telehealth visit is really important. And also thinking about how, so a lot of providers did end up incorporating telehealth as part of their prenatal and postpartum care during the pandemic, when insurers were reimbursing at higher rates for telehealth, and some of that has unfortunately gone away, and it's made it harder for some of them to maintain that. So I think thinking about equity and financing issues around innovations and how patients get access to care, especially postnatally, is really important.
Thank you. I'm going to leave you with one last question for each of you. You know, when I'm mentoring students and others, they say, you know, what should I do? Where should I go? Should I follow my passion? I say, don't follow your passion, because you're going to do that anyway. Follow your curiosity. So what are you curious about relative to improving the health of mothers and infants and families in our society? What are you curious about? Thea.
Well, you know, not to keep saying the same thing over and over, but partnering. I think, you know, how can we think about working together to solve some of these big issues? And, you know, just taking each issue piece by piece and figuring out how we can work together. You know, I know even on the payment side of things, although no one is, you know, from a public health standpoint, exactly where folks would like us all to be, there's a lot of great things happening. And lots of amazing conversations and groundwork happening on how to remove barriers and how to maximize support for, you know, both what communities are asking for as the solutions, as well as what we think will work best. So I'll stop talking and let my policy friends talk too.
Julia, what are you curious about?
I'm a researcher and I'm a complete data nerd. Like, that's what makes me so excited, is data. And unfortunately, that's one of the things I mentioned. We don't have good data, especially in postpartum health. And I think I am curious about ways we can improve data access and how we disaggregate that, and how then we can use that data to talk to legislators and be more effective in communicating what the problems are, and how we can then pinpoint policy solutions and then evaluate those solutions. I think that's an important component that's often left out of policy making, is the evaluation part, to prove where there are successes or where there are failures, that then can support those policies going broader, or removing ones that aren't working.
Yeah, good. And Susan, where's your curiosity leading you?
Well, it's similar to Julia. I mean, I have curiosity about, you know, research questions. So particularly, you know, as we get more information that policies can, for example, prevent child abuse and neglect on average, what do we know about whether they can narrow disparities in child abuse and neglect? Because we know sort of often universal policies can actually widen disparities, you know, as a sort of more privileged group takes advantage of resources. So that's a sort of academic curiosity. But more sort of urgently, I have this sort of ongoing question about how does developing that evidence base actually make any difference? Because we see that you can have all the data and all the answers in the world, and it doesn't necessarily change anyone's mind or change policy. And that's something I know nothing about. I'm an epidemiologist. And I don't know that I will be someone who will be ever become expert in, I don't know, policy advocacy. But increasingly, I feel like that's really important. Like we kind of sit in our academic spheres and think that if we develop the evidence that something will happen with it. And that is clearly a misguided assumption. So I'm curious to know more about that world, that translation piece.
Good. Well, thank you all. Thank you, Thea, Susan, Julia, really good presentations. Thank you for responding to the questions. As you probably could tell, I'm getting old and maybe I'm just getting crotchety, but I'm just really irritated the fact that in the 50 years that I've been in healthcare and public health, we really haven't made substantial progress. We are struggling with the same things. And despite great medical care and great public health, we are just not making the progress. And so I think it's just, I'm getting crotchety in my old age. But still remain hopeful. And I do think the thing that we really need to do is actually, as Susan was talking about, how do we change? I think we have to change the narrative. We need to, about what creates health. It is not about individual choices and just about individual choices in medical care. It's really about the conditions in which people live. It really gets at the fact that health is not an individual thing. Health is in relationships. Health is in partnerships. You can't be healthy by yourself. You have to be in a relationship. And we have to be accountable to one another. And so I think that's what we need to do, is think about how we change the narrative about what creates health. And that's probably the biggest thing. And so I'm going to end, and this sort of reflects the fact of how little we've changed. I'm going to end my session here, this little piece, with what I ended my talk in 1985 in front of Senator Durenberger and Senator Childs in the National Commission to Address Infant Mortality. I said, the problem of infant mortality in this country is an issue of social justice. The survival and growth of infants and children depends on our acceptance of the responsibility to address their pressing medical and social needs. To ignore that responsibility would be an injustice, not only to our children, but to our society. We need to make a commitment to the children of our country. We need to make them our highest priority and protect them from the political, social, and economic forces that pervade our society, and too often to the detriment of families and children. This is really a battle for, actually, this, I think, the soul of America, which is kids and families. And so we need to make them our highest priority, which we have not done. They have not been politically powerful. They are not economically powerful, and therefore they don't fit into our system. So let's work on the narrative. Let's keep kids and families the centerpiece and make them our highest priority. And then let us have MPHA close out the session by telling us what we need to do next. So thank you all for a great session.
Thank you.
Thank you, Ed. And I'm going to turn it back over to our president, Liz Moe.
Thank you, everybody. There's always a place for righteous anger, especially if it's backed up with data and passion. Thank you to all of our panelists, and thank you, Ed, for our speaker. It is the synergy, the energy between all of you and MPHA is the best reason to wake up in the morning. Thank you. Thank you to all our participants for coming. Lindsay is sharing the upcoming forums. I also want to point out that MPHA has a lot going on this year. And I keep coming back to our vision to be an independent voice for public health in Minnesota. And so, we're really working with all of our partners to be that independent voice. And now more than ever, we need voices outside of the established systems to be able to keep raising some of the most obvious but overlooked challenges of our time, and to keep advocating for what the public health community needs on behalf of all of Minnesota. One of the things MPHA is doing that I want to point out that relates to so many of the comments today is we are positioning ourselves as in terms of racial advocacy and equity. And so there will be a survey coming out to all MPHA members, and I would encourage all of you to take the survey because we're trying to better understand what our members, where we are in terms of our thinking about health disparities, about equity, about racial differences. And that's something that I'm hoping will only take a small amount of your time, but will make a big difference for MPHA. And again, we have these great forums coming up, challenges in food and nutrition and challenges in coordinated global response, where we'll have more time together to take on these challenges. Check out our website and our upcoming events, and we look forward to seeing you soon. Thank you very much.
Thank you all. Have a great rest of your day.